So it's 5 to 5 on a Friday, and you've already chosen the show on Netflix you're going to watch. You're finalising the pizza toppings, and you get the call. It's the emergency department. A new patient has presented unwell, unsure of their medications with a potassium of 8. Their renal function seems off. The creatinine is 200, 2.3 if you're American. But it's unclear if this is even a new problem. Someone is whispering into the ear of the caller. It turns out they're hypoglycemic as well, and the ECG is T waves that look a bit peaky. So now what? Acute hyperkalemia is a common medical problem and one that everyone should be able to deal with. And it can be very satisfying to treat because you can usually work from first principles to build an understanding of what's happening to your patient and ultimately to help them. Now, we aren't going to talk about chronic hyperkalemia today. The same pathophysiology applies, but there are slightly different treatment considerations, and it's unlikely to interfere with the aforementioned pizza and Netflix, so it shouldn't really be a key learning priority when you consider hyperkalemia on the whole. Now, we do need to review a few fundamental bits of potassium physiology. I promise it'll be easy, and I'll keep transporters to an absolute minimum. Only going to refresh things you actually need to be an effective clinician. So the first thing you need to remember is that potassium is predominantly inside of your cells. Only a little bit exists at any given time in the interstitium, outside in the blood compartments. Here, it's important to maintain that transmembrane electrochemical gradient, which allows cells to depolarize and to repolarize. So it's obviously very important then in contractile tissue, like your heart. And spoiler, potassium and hearts are a bad mix. In situations when potassium rises in your blood, a cell has a very limited capacity to absorb the additional potassium, because in doing so, it's also going to diminish that electrochemical gradient to make it more likely to depolarize at the wrong time. And this is how little baby arrhythmias are made in the heart and are born. In short, the way that our bodies deal with this rising potassium is by buffering it out into the skeletal muscles. And there are 3 key factors that you should know about that regulate this movement under normal conditions. And they are insulin, catecholamines, and acid base. Now, in the case of insulin, and hopefully it's endogenously produced and not in a syringe like here, potassium is shunted into the cells via the GLUT4 transporter. And that's actually really cool to know because it's a different mechanism to the way that insulin controls your sugars. So if you have metabolic syndrome or CKD, where your insulin-mediated glucose uptake might be impaired, your potassium can often remain normal, which is, I guess, a silver lining. Exercise is also associated with that movement of potassium from the interstitial space into skeletal muscles. During exercise, catecholamines are released, and through beta-2 stimulation, then it's going to limit that rise of extracellular potassium that otherwise would occur as it leaches out of all your contracting muscles. When I was in medical school, I was told that as H+ builds up in your blood, which is essentially all acidosis is, it simply forces itself into the cells and replaces the potassium, which is forced out of the cell. Sadly, despite being really easy to remember and conceptualize, it's actually incorrect. The general effect of acidemia is to cause potassium loss, not because of this direct exchange, but rather it's an apparent coupling resulting from the effects of acidosis and transporters that normally regulate pH in the muscle cells. But you know what? You need to have a schematic that lets you understand this stuff so you can actually work day to day. So if it's easier to conceptualize the incorrect way, you've my full permission to pretend you didn't hear the last bit. So the final and most important part. 90% of your potassium is removed via your kidneys. 10% is in your feces. Not particularly useful to know most of the time. So let's just kind of focus on that most magnificent of organs, maybe the greatest organ, depending who you ask, the kidney. Now, without these, you'd be swimming around in the sea, just because these beautiful tubules are all that allows you to maintain your salt and water balance just right, regardless of what's going on around you, so you don't need to be surrounded by salty water. Now, potassium is freely filtered by the glomerulus. Now, what that means is it passes through that sieve in the capillary endothelial membrane and through those fenestrations. And as the fluid gets forced out, it just takes the potassium along for the ride. Now, most things that are freely filtered are quickly reabsorbed. It's a bit of an unwanted side effect on the glomerular system. It's a bit too leaky sometimes, to be honest. Potassium is no different. The bulk of filtered potassium is reabsorbed in the proximal tubule and the loop of Henle, such that it's about less than 10% of that filtered load that finally makes its way to the distal nephron. Very famous transporter, of course, in the loop of Henle, the sodium potassium 2 chloride transporter, which is the target of loop diuretics like furosemide. So now as potassium continues to surge along that water slide in the nephron has the option to pump a little potassium back out of the body into the urine as it cascades along the tubule towards the bladder, later into a toilet bowl or nearby tree or whatever. Potassium secretion, which is what this is called, begins in the early distal convoluted tubule and progressively increases along the distal nephron into the cortical collecting duct. And this is where the magic really happens, and this is clinically the most useful part. So lean in and we'll take a little look at what's actually happening on a cellular level. So here we've zoomed into these principal cells, which are the ones that secrete potassium. Now this isn't a battery, this is my diagrammatic attempt to show you that there is an electrochemical gradient across the tubular membrane here. And it's a little bit more negative inside in the tubule where your urine is. And this negative charge is very important because this is responsible for the large proportion of the secretion of your potassium in there. Potassium is positive, it wants to flow down into the negative and balance things out again because the universe doesn't like things when they're not in equilibrium. It likes things to be nice and level and balanced wherever it can, and it will go out of its way to do that, and you have to actively oppose that phenomenon. Let's check out the key players then. The magic ingredient here to really juice up the secretion is aldosterone, which is a mineralocorticoid. Aldosterone's first trick to ramp up this is to increase the potassium intake into the cell. This is going to stack up the gradient nice and high. You've got 3 bananas instead of 1. And it's going to make it easier for it to flow downhill into that tubule. For its second trick, aldosterone can also pump back some of that incoming sodium out of the urine. Sodium, of course, is going to be flowing down the tubule. You filter it just like you do potassium. You reabsorb it in a similar kind of pattern. And ultimately, this is going to end up in the toilet if you don't do something about it. And aldosterone is going to reabsorb it back into the principal cell, out of the tubule. And what that's going to do is taking a positive charge out of the mix is going to make it relatively more negative in there. And that again is going to be exactly what potassium wants as it flows into the negativity. As an aside, you now know how aldosterone antagonists, like spironolactone, the most famous one, have their diuretic effect. If it stops this sodium getting back into the body, and you end up excreting a thing that you need to know is flow rate, of course. The faster the urine is cascading along this tubule, it is going to flush away the sodium, it's going to flush away the potassium, crucially, and it's going to keep a negative charge there. If you didn't have very high urinary flow, your potassium that you excrete would just build up and build up and build up, and you'd lose the negativity, but you'd also lose the potassium gradient itself. So a nice high flow rate sweeps everything clean and keeps things moving efficiently. So let's review then what we need to get potassium into our urine. You need a kidney that can actually make urine. Don't underestimate the basics. You need your acid-base situation to be relatively normal. Aldosterone, you've seen, is really important, so you need to have some of that. You need a good urinary flow rate, and ideally you need some sodium in that urine that you can pull out with aldosterone and make that gradient. So now you know how potassium is excreted through the kidneys. Let's move on to actual hyperkalemia. When it's too high, what's all the fuss? Is it even dangerous? Well, in the ITU and critical care world, it's certainly strongly associated with poor outcomes. Here, for example, a Korean group study of ITU admissions, they did find hyperkalemia to be associated with increased risk of death. And it was much the same in this large cohort of American patients, 39,000 patients here, and you can see that at higher levels of potassium, you have a higher chance of dying over time. The issue, of course, is that while these are large, they're still retrospective observational studies. It's hard to pin the actual blame onto the potassium itself. Is hyperkalemia just a marker of worse acid-base balance, or worse kidney injury, worse sepsis, for example, or very severe disease phenotype like tumor-lysis? What's worse is that it's not even proven well that treating hyperkalemia actually decreases the mortality. Now, you'd be alone if you thought that it wasn't worth treating very high acute hyperkalemias. I mean, absence of evidence isn't evidence of absence, but it's worth knowing that actually you're working in a very data-light situation, despite the fact that this feels like bread and butter medicine. This illustration of this weirdness with hyperkalemia is when you consider the odds of dying within 24 hours when admitted in this graph. A higher number on the bar plot means you're more likely to die. It's an odds ratio. And at first glance, you might think there's a protective effect with higher stages of CKD, despite these people having more advanced disease. Consider, how easy is it to generate hyperkalemia with a potassium of over 6 when you have CKD stage 5? Honestly, a large bag of pretzels or fish and chips might do it. Compared to somebody with pristine kidneys, for them to get the same level of hyperkalemia, they need to be really unwell, perhaps a severe sepsis or a DKA with dehydration. And when you start to think of it like that, you see how fraught with difficulty it is to disentangle the individual contribution of potassium from any one person's risk at any time. Do you want to read more? And you should. There's a very succinct review that I really recommend that highlights a lot of the key research and the lack thereof in some areas. You send your junior colleague down to ED while you finalize your pizza order, and he sends you back a postcard. So you read his postcard just as you begin your handover, and Dr. I'm a crap doc thinks they've nailed it. Treated the hyperkalemia accordingly. So take a moment to consider what they have done, and if you can't see any problems, don't worry, because by the end we'll review this and perhaps you'll see a few. Now, the most important thing to know about hyperkalemia is that it isn't a disease. It's, in my opinion, it's not even a proper diagnosis. It's a symptom of something else, and your job as an astute clinician is to uncover the underlying issue and fix that. Otherwise, you're playing whack-a-mole with a number on a blood test for days as your patient is going to get sicker and sicker and sicker while you're distracted by arbitrary units of potassium. Now, in many situations, medicine can be simplified to help us think through them, and hyperkalemia is no different. So here are 3 broad strokes to frame the problem. So you may have too much potassium getting into your body, and that can be exogenous, that means from outside your body, so your diet essentially. It can be endogenous, remembering that all of your potassium is in your cells, so if your cells are breaking apart for any reason, they will release all of that potassium, and you need to be able to deal with that. You may have potassium in the wrong place. In fact, you may have a normal amount of potassium overall, but you just have it outside of your cells instead of inside. Acids, as you've seen, can be a classic cause of that. And finally, you may have a problem removing it from your body, kidneys being 90% of your total excretion, so by far the most important. There may be a combination of many of these issues, but you need to take a step back and think as deeply as you can about the situation and not allow yourself to be lulled into the false sense of security by reaching for protocol. Star Trek fans will remember Captain Lorca saying it best in Star Trek Discovery.
Universal laws for lackeys. Context is for kings.
And I really believe that. Context in medicine is everything. So you need to keep needling yourself continually with questions to try and understand the situation from every angle. Cross-examine yourself like a lawyer. Here are some pretty sensible questions that you can ask yourself as you take your history and start to formulate a really in-depth understanding of the situation. Ask yourself, do you really know what happened? Is it a new problem? Does this patient even have a kidney that I can rely on to remove this potassium? Is it going to happen again? You tend to operate in 2 to 4 hour intervals when you're dealing with severe high potassium, because most of the therapies you can give will only last for that long. So you need to be a bit forward thinking. It's not enough to deal with the number and then walk away. Now, what tools do we have at our disposal to understand hyperkalemia? Well, the trusty ECG is sadly overrated here. To illustrate, here you can see the higher your potassium, the higher the green bar, which is the percentage of patients with an adverse event. The hyperkalemic changes in this study didn't correlate with the events at all, really. Everyone's favorite ambiguous change, the peak to T wave, didn't correlate with events either. Although the fact that patients were obviously going to be treated for the hyperkalemia is a vital confounder to interpreting this. So ECG changes are inconsistent and don't always occur as you might expect them or want them to, and they can be inscrutable in terms of their predictive power. Here are just two more examples of a small body of literature that really undermines ECG as a useful tool. Here you see ECG is rather unreliable at generating changes, and even in potassiums over 7.2, more likely not to have an ECG change in this particular study. And the potential ECG changes that can occur in the context of hyperkalemia, they grow legion with each year. If you can dream it, hyperkalemia can probably cause it. And I've encountered and written about hyperkalemia leading to pacemaker capture failure. So really, when potassium is high in terms of rhythm disturbance and control, all bets are off when you consider how unstable that myocardium can be. A final example to illustrate even further the weirdness of ECGs and hyperkalemia is this poor soul who incremented their potassium by only 0.1 over 6 days. But that was apparently enough to turn a normal ECG into a kind of sinusoidal wave a toddler might scribble on your wall in crayon, okay? And for all the foibles of ECGs, this is the kind of tracing that would upset even the most hardened of physicians once they see it. And when it comes to drugs, the BNF or your local formulary are always going to be your best friend, but some classics to remember include beta blockers. And now you hopefully understand this is by blocking the natural phenomenon of beta-adrenergic agonism. ACE inhibitors or ARBs are notorious for this, and while it's certainly okay to stop them acutely, usually, make sure you understand why they're on it, you should always have a plan to restart these because these are life-saving drugs over time. You won't be doing a patient any favor if you allow their kidney disease or heart failure to progress years earlier by forgetting to restart them just because they had hyperkalemia in the context of diarrhea, for example. Tacrolimus is worth mentioning here too, not because it's particularly common, but you're going to encounter this in solid organ transplants generally. And when you do encounter hyperkalemia in this context, it's important never to stop this without discussing with the relevant team or expert. It's almost always a bad idea. If in doubt, don't do it. So now we must at last do something about the pesky hyperkalemia, but what? For an entertaining jaunt through the evidence, or the lack thereof behind the interventions, I do recommend this excellent Cochrane review that will open your eyes to the folly that is the received wisdom in hyperkalemia. And I really like that they don't use the word treatment here, and they went with interventions instead, because the T word might trick you into thinking that you're actually fixing the problem. You're not. You're just buying yourself time and breathing space so you can fix the real problem. So I'm going to call them temporizing measures. Temporizing measure number 1 is a humble insulin, just like your body makes. The big risk here is hypoglycemia, which is common. Now, hypoglycemia is not something to be sniffed at, and it can really do some damage. And even small temporary dips can set wheels in motion on a ward. I'm sure many will recall a simple fall which could be precipitated in an elderly patient by hypoglycemia. Next thing, you have a broken hip, a post-op pneumonia, the inevitable sepsis, and finally a tragic death which could have been avoided if we really nailed the bread and butter stuff, the basics. Always check your blood sugars after giving insulin, in this context in particular. Do take responsibility for this if you prescribe it. Now, common sense is useful as ever here. If their sugars are low, give them some extra glucose. Don't panic, but don't let that stop you from using insulin. Even better, give them something physiological like oral carbohydrates. If their sugars are high, make sure you have a good explanation for this. Perhaps an infected diabetic who skipped their own insulin, so reintroduce it. Just give some extra. So don't be fazed by the sugar. Keep calm. Modulate that sugar in parallel to what you're doing. And remember, you can just keep rechecking things. And if you keep rechecking things all the time, and it allows you to react in a timely manner, and you can really head off most disasters on a ward if you just keep your eyes open. For those thinking about exams, those with diabetes often do end up running a bit hyperkalemic. It's likely a combination of a relative insulin deficiency and renal tubular acidosis type 4, which diminishes their ability to secrete potassium. So the second temporizing measure, beta agonists. Beta agonists, the opposite of a beta blocker, are the mainstay of beta agonists, the opposite of a beta blocker, are the second mainstay of this temporizing measure. Here you see the black dots are salbutamol nebs, the white ones are formoterol, a different type of agonist. As you see, if you give higher doses, you get lower potassiums. Beautiful. And on the right, you'll see it also bumps up your serum glucose. Now, that's a very useful side effect when you consider you're going to be co-administering this with insulin often. And the evidence that does exist, which isn't much as you can see, is really for doses of 10 milligrams or more. It is additive to insulin and is protective, as you just saw, from hyperglycemia. Sadly, it doesn't buy you much time. It's actually only about 2 hours, isn't it? And it's worth noting that up to 40% of patients with CKD may not respond at all. So don't rely on it. The third cornerstone of your approach is going to be calcium gluconate. Now, it doesn't lower serum potassium, rather it stabilizes cell membranes and restores some of that oh so precious electrochemical gradient. This is a drug that saves lives. It's often prompted by scary ECG changes, which is fine. But honestly, how can you justify limiting your usage of it to an ECG change, knowing what you now know about the ECG? How can you not give calcium gluconate if someone is extremely and suddenly hyperkalemic? I personally lean towards giving it if I'm worried. It comes with side effects. It is not a benign treatment necessarily. And extravasation can be nasty if it happens. I'd rather have blisters on my legs than ventricular fibrillation. But do your best to have a decent cannula to minimize the chances of this happening. Another exam tip is the pseudo-axiom, that is, advising caution in digoxin therapy. An axiom is one of those pithy universal truths handed down through generations in medicine, like you're not dead until you're warm and dead, which reminds you never to give up on a hypothermic arrest until you've warmed them. Well, a pseudo-axiom is something that sounds pretty good, but it's actually rubbish. So the theory went that you could lose your heart's contractility as you gave this surge of calcium in a heart with digoxin toxicity. A stone heart syndrome, they called it, but there's really no evidence to support this, and actually there's mounting evidence to refute it. So if somebody mumbles about stone heart syndrome to you in an emergency situation, I would be pretty confident giving the calcium myself. Calcium resonium exists, sadly. I'm not going to dwell on it other than to say you should never use it. It doesn't really work. It hurts people. That's basically it. Now, I have a soft spot for intravenous bicarbonate. It has managed in my practice to shave a little bit off people's potassium while bridging them towards something more definitive like dialysis. In terms of good evidence, I cannot hand on heart say there's more than a few dozen patients in the late 90s. That's about it. And I sometimes wonder if the authors, when they wrote to the East African Medical Journal or the Journal of Korean Medical Sciences, knew that their relatively humble research papers would be the sole evidence for the entire planet's approach to a common emergency. And you can't say that about most papers in the Lancet, can you? So let's summarize. In your patient with hyperkalemia, you need to stop this nasty potassium getting in. You need to correct any abnormal shifts of potassium, and you need to get it out. If you try to remember always the physiology and what is wrong with your specific patient's physiology, you won't go too far wrong. So ensure they have a kidney, ensure it pees well, give them some salt, and ensure they have enough aldosterone. If your back is really up against the wall, the big red get out of jail button is dialysis. It will rapidly drop potassium, and sometimes it is the only option. That's really very rare on, say, a medical ward, especially in somebody who has some native kidney function. It would really be a shame to need to resort to dialysis in someone who has kidney function to deal with hyperkalemia, and quite unusual really. There are new drugs emerging in recent years. There are oral potassium binders now that are much better than the binder that shall not be named, but they take hours to kick in, and they don't really have much of a role in acute treatment at this point. They still have to find their place, I think, in the grand scheme of potassium management. Probably will be useful in helping buy people time when their levels are not super high, but they need a few days to get perhaps dialysis access. With a suggestion there may be a role in allowing us to give hyperkalemia generating medicines, perhaps such as spironolactone, a bit more safely. It remains to be seen whether that's a good deal. So to return to our postcard, I hope now you can see a few elements that are suboptimal. Hyperkalemia isn't a diagnosis. You don't really have an idea what's going on with this patient right now. They've underdosed salbutamol, a cavalier attitude to the blood sugar monitoring, tenuous grasp of the role of the ECG, and footnoting a rather sporting level of 8 is probably not a great sign. At some point, it's good to refresh your memory of what foods are full of potassium. You're not likely to see many of these on a patient's bedside locker. You're probably going to see things like crisps instead, but nuts, tomatoes, avocados, bananas tend to turn up now and again. Slap them out of their hand and call the dietitian to have a chat with them. Finally, an interesting case I did find when I was doing a bit of research for this was death by coconut. A poor gentleman working as a construction worker in New York in the hot summer sun, he drank 2.5 liters of coconut water. Potassium hit 7.8, and there's certainly convincing ECG changes there, although, as you've seen now, I'm not really sure what it means. It didn't actually die, thankfully, which means this title is a little bit clickbait, isn't it? But we'll let them off. So, a final summary. Context, as in everything, is king, but definitely in hyperkalemia. Don't trust those ECGs. Don't trust your insulin. Keep checking your sugars. Don't trust salbutamol if they have CKD. Don't trust yourself, actually, while we're there. Just keep asking yourself, have you fixed the real problem? Healthy suspicion goes a long way in medicine. Do the protocol, absolutely, but if you don't understand what's happened, you've probably missed something, and it's coming back for you. Final parting gift, pseudo-hyperkalemia, aka how to impress everyone on your team. Pseudo-hyperkalemia occurs when all of that potassium inside in your cells leaches out into the serum after the blood sample has been taken. So it's not real. In your body, your potassium is fine. This is a phenomenon that is artifactual. Anything that gives you lots of cells can cause this. So thrombocytosis, erythrocytosis, blood cancers, and so on. GP samples, so if your community provider is sending in a sample and sitting there for many, many hours, the normal level of cells even can begin to leach out their potassium. If they store it in the fridge, it gets worse because the pump that keeps the sodium and potassium in balance is less effective in the cold. The solution, check a plasma sample. That's an ABG, an arterial or venous blood gas, most of the time. Or if your lab can do a plasma for you, by all means send it off. So I hope that was helpful. Thanks very much. If there's anything else you'd like me to cover in future, just reach out, get in touch, and I'll be happy to oblige. Thank you.